Hello. Our next topic will be the complications and the outcome in non-syndromic craniosynostoses. As you know, this topic is dominated by the intraoperative complications related to bleeding, and it is one of the major concerns when we decide for this kind of surgery. We know that children have a limited blood mass. At birth, the blood volume is about 250 milliliters. It rises to 500 at 3 months and 750 around 9 months, which is the age where we have to do major surgeries with blood loss and very often requiring a transfusion. So it's a large undertaking. It can be fatal if uncontrolled. One of our friend anesthetists said that the surgeon cures the patient, but the anesthetist ensures that the patient survives the cure. And a transfusion saves lives, and obviously we never let a child bleed to death. And this is a concern that maybe the parents when the parents are Jehovah's Witnesses, for example, they are very concerned of the risk of blood transfusion, and obviously we do whatever we can to limit the risk of blood transfusion, but clearly intraoperative bleeding is still a concern. So when do the children bleed and why? At the time of the scalp incision, of course, then the superficial dissection. This is a metopic synostosis, and you see we have very often transosseous vessels at the place of muscular attachments of the temporal muscle, and also on the pterion. Very large transosseous veins in the metopic area, and also the anterior ethmoidal vein. And finally, when we remove bone along the greater wing of the sphenoid, we can have important bleeding. So there are many sources, and we have to do step-by-step hemostasis as long as we prepare the bone surfaces and we do the osteotomies. We have to do hemostasis very thoroughly. So then we have bleeding from the dura mater, from the middle meningeal artery, and the arachnoid granulations, which appear around 8 months old when the child begins to stand sitting and walking. The bleeding can be aggravated by the raised ICP, by hypercarbia, and respiratory pressure, hypothermia. So this is another reason to have many exchanges with the anesthetist. So here you see the transosseous vein in the metopic area in metopic synostosis, and operatively we use bone wax, a lot of bone wax in these patients, and also very often we see the parietal emissary veins when we do a sagittal synostosis. So wax, wax, wax. So should we consider that transfusion is really a complication? Obviously, it is inherent. The risk of being transfused is inherent to this surgery, so we have to be prepared. There is no excuse for not being prepared. We can do some iron fortification, use the EPO before surgery, but it has a limited impact. It helps. Positioning should be very careful with the head lifted, no venous compression. We have to prepare with a deep venous catheter. Sometimes, very often, the anesthetist decides to put an arterial catheter. And as said before, a step-by-step hemostasis. And recently, we have introduced the near-infrared spectroscopy, which helps in some surgery, for example, scaphocephaly operated in the ventral position. It helps decide at which time transfusion may be needed. And obviously, we need to communicate with the anesthetist. It is a leitmotif. However, we have complications of the installation and preparation, like the arterial catheter. The intravenous catheter can cause necrosis in case of leakage, and it can be aggravated by the ID band around the foot. We can have necrosis of the scalp due to the headrest, which can take time to improve. And all this shows that we have a shared responsibility with the anesthetist, and security comes at a price. Dural tear can be a serious complication. It can be caused by the burr initially, or by the craniotomy if we have insufficiently elevated the dura mater from the bone. And we have to remind that the patent suture are very adherent to the dura mater, and it is especially tricky in unilambdoid synostosis, because very often the transverse sinus is occluded on the synostotic side. That means that the non-synostotic side is facing a very large transverse sinus, and bleeding could be very treacherous. And also there is a scarring when we redo surgery because of the previous surgery. Also, we have to be careful of lacunae when there is this sort of cloverleaf skull. And in this child, operated at 9 days of life, there was a small dural opening close to the sagittal sinus, which could have been a problem. And we have to do the craniotomy doing tango steps to avoid dural tears. That means 2 steps ahead, 1 step backward, to avoid biting the dura mater with the gouge. So the consequences can be venous bleeding, as said before, and growing fracture if we do an opening of the dura and we don't repair it satisfactorily. As I said, the trepanation can cause a dural tear, especially at the point of the keyhole. And there is a good reason for that, because the pterion has a shape, triangular shape. That means that the corticals are not parallel. That means once you have passed the first cortical, you should change the direction of the burr to approach the inner cortical to avoid dural tear. Then we see the postoperative complications. First, we have to take into account the emotional shock of the parents for many reasons, because of the edema, the child is disfigured, because of the chemosis, which can be major, and many of the children take up 1 kilo between during the surgery because of the abundant infusion. Which can cause ocular problem, and also after the edema subsides, the child changes in appearance, and some parents are very upset and say it's not my child anymore, and it has to be anticipated. And also there is a mirror effect. When the parents are anxious, the child gets anxious, and it aggravates each other. And so it results in sleepless nights, which can last for 1 month or even more, with co-bedding and so on. So it can be really a serious condition for these families, and they have to be prepared in advance. We have to be advised that swelling is normal. It will subside in a few days. It's important to promote the cradling and the cuddling of the child by the parents. It saves morphine, because the stress is less. And the parents also have to be convinced that the head will be more normal than before surgery. That's the reason why you operate the child, is to make him the head he should have had. Operative infection is a rare occurrence in this surgery. However, we can have inflammation of the scalp, especially with absorbable suture. In some cases, we have to remove the absorbable suture before the sheds themselves because of the inflammation, but it's not so important. It is easily managed. We can have scalp necrosis, which can be difficult to treat, and it happens especially if we do a big calvarial expansion. So we have to remove the scabs to treat locally with local antiseptics and sometimes antibiotics until it heals. And sometimes we can have a deep suppuration, which requires antibiotics, sometimes drainage. but in most cases we can treat them conservatively, not removing the cranioplasty, which would be a real disaster. In this case, we had a severe empyema, which was treated by irrigations and dressing for a long time, and it could be we managed to preserve the morphological results, and the patient was cured without new surgery. In this case, we did irrigations for several weeks and even months, and in the end, she managed to heal without removal of the bone. So it's important to try all means to remain conservative. How can we prevent this infection of the operative site? During opening, we have to incise at right angle and not like this, because it would leave a margin of skin apparent. There is obviously no good closure for a poor incision. We do a subcutaneous suture with inverted knots so that there is no thread appearing on the skin. And we use local antiseptics, and sometimes we have some scars to remove. There may be a breakdown of sutures, especially when there is a large, a big enlargement of the calvaria with a skin closed under tension, and especially in redo surgery when the skin is especially stiff. And it has also to be anticipated. And in some cases, we may need to do a scalp expansion by this kind of balloon, which helps to close without tension. We can have a breakdown of constructs, which is a rare occurrence. It's not caused by trauma, it's caused by the tension of the scalp when we close back. Here, we had the bandeau was not fixed adequately, so it was lordotic, and we had to reoperate. And in this case, it's another one in which we could reapproximate the margins of bone, and because otherwise there was an encephalocele just below the eyelids. It was very ugly. So it is important surgery. It is a grade 3 or 4 Whittaker grade. Threads and wires can leave some complication, especially if some wires are not adequately turned around to not to show up under the skin. It can even cause, it can even threaten the skin and need some new surgery to remove them. It's a rare occurrence, but probably these wires can be avoided and replaced by absorbable suture. However, it has they still are used and may be very useful in some cases. And we have also to anticipate that will grow as the calvaria will thicken outside and absorb inside, so that the wires will become adherent and can become embedded in the dura mater without complications, but it has to be anticipated. Plates can also cause complications. I don't use them much, but it has been reported in the literature. It can cause a breakdown and also extrusion when it is a non-absorbable construct like platinum mesh, and also some inflammation and foreign body granuloma. Lacuna can develop on the long run, especially in older children. It is associated with a technique. If we remove too much bone on the midline in scaphocephaly, if we don't respect enough the periosteum, maybe, And I think for metopic synostosis, it is better to make a three-dimensional construct which provides depression in the epidural space and enhances reossification better than if we apply bone just on the dura mater, and it is destined to absorb. So this lacuna can close spontaneously, but after 5-6 years, maybe they require reoperation. And lacunar repair is done best by split calvaria. Here we have the receiving site, and we split the bicortical bone like a cookie. We cut in the cancellous bone, so we have two cookies, and we can repair the donor side and close the receiving site and have a good reossification. But we have to make a rigid construct in order to ossify well. Growing fracture can happen if there is an unsutured dural tear or if there is a dural necrosis. It causes a brain herniation like here, and it can also be aggravated by an underlying CSF circulation problem. So the closure may require drainage. Here we use the lumbar drainage. And again, it is best made with autologous graft with a split calvaria and a pericranial graft like here, and in this child who was 1 year old. So this is a major undertaking. It's a Whitaker 4 grade. So what about the morphological outcome now? First, this is an example of the metopic synostosis with the points we want to correct, and this is how we manage it. In this case, we were happy with the results, but it may be not so satisfactory from the patient's point of view, because maybe our goals are defined by the technique we use. That means if we achieve the surgical bone we have, the surgical goals we have defined, we may be satisfied, but the patient may not be. And another question is, are we better than the nature, and are the results better than natural history? This is an example of the typical problem we have in metopic synostosis. There is a temporal hollowing which develops with time, and at the age of adolescence, it can become problematic, like in this young boy. So it is obviously related to the technique. The bone does not grow well, maybe because in this region it should be under tension because of the temporal muscle. We don't know, but this can require a correction by lipofilling, ideally. It can be prevented by the technique using the elephant ear, like we use as shown here, but it is not always satisfactory. This technique involves metopic space because we enlarge a lot the forehead, which is the aim of this surgery, and it creates a void. But this void very often fills very fast. In a few months, it is ossified, and generally it gives a good result, but not always. In this case, frontal bosses were a bit too high and appear to correct with time, but we note that this child keeps some hair to conceal the frontal bosses, so maybe. And in this case, obviously, it was not satisfactory. There was an overcorrection of the frontal bossing, but it enhances the temporal hollowing instead of concealing it. The incision, it obviously leaves a scar, so we try to make the scar as a stealth as possible, using the stealth incision or the zigzag incision or the lazy S. Whatever we do, there is a risk of a keloid scar and also a scar caused by the drain, so now I avoid drains. And the aim of the incision is to be at 90 degrees from the direction of the hair. So when the hair grows and thickens, it will conceal the scar. But in fact, many children don't care at all that people see their scar, as you see here, and even in some cases, they have the idea of magnifying their scar, which obviously had inspired his hairdresser. There is a problem which is very little talked of. It's the irregularity of the bone surface, which happen with differently according to the technique. Here you see there is a layer of bone which is thicker along the skin incision, which is probably due to a curled periosteum which leaves an ossified cushion, of which sometimes the patient complains. We reassure them that there is not a problem, but if they talk about it, it may be considered as a problem. Also, we can have some nodules, which here are more important, maybe enhanced by the absorbable plates. And some patients complain about it, but we try to dismiss these complaints and consider it a non-problem, because otherwise the result is okay. But however, if the patients complain, it may be a problem, and maybe we don't consider it because we don't have a good solution to propose, and because it would involve repeating the scalp incision, which would be a big undertaking, and we have no other, in fact, we don't have a solution. So maybe that's the reason why we dismiss this problem. But it has to be prevented, and I think the best way to prevent it is to respect as much as possible the periosteum and avoid the subgaleal dissection, and also maybe avoid the absorbable plates. So what is we have spoken repeatedly about the Whittaker score, which considers the rate of reoperation. One, there is a problem which does not require surgery, or maybe we don't have a good surgical solution. Two, it requires a minor surgery like lipofilling. This is a typical example of Whittaker 2, which is very worse because we have a good solution for this problem, which is lipofilling. Three is a redo surgery, and four is a major reoperation, as large as or even greater than the first surgery. It can be because of the result which is incomplete, because of surgical complication or progression of disease, but it does not indicate whether it is a failure of the technique or a progression of the disease. So it's the Whittaker score is very imperfect if we are to evaluate the surgical results. And it does not allow the pre and post-op comparison, obviously. There is a score which has been proposed by the team in Leeds, which was in mindset of the NHS, which is taking in account the cost and the duration of hospital stay, and based on the timing and gravity of complications. So it was an interesting initiative. And I think what is most wanting in this discussion is the morphology scores, which are difficult to establish because there are a lot of biases. Generally, the surgeons, as I said, judge the results relatively to their expectations based on the techniques they used. The parents are always satisfied, which often means that they don't want us to touch their child again. And so it is important to try to define objective morphology score, and the team in Rotterdam is at present studying morphological evaluation, and it is very interesting to follow. So, as I said, there is a big question in metopic synostosis. Is our surgery better than natural history? Does metopic synostosis improve enough? And does the surgery justify the benefit risk ratio? So this is an example of a previously trigonocephalic child who became a wrestler. He must have had a terrific headbutting, and he became a famous actor. And this is a kind of extreme metopic synostosis. And very obviously, this trigonocephaly does not disappear in all cases. This is a young boy, 5 years old, who still has a severe metopic synostosis. And this was a 6-year-old child who was harassed at school because of her metopic synostosis, and she was in demand of being operated. So this is an unsettled question, and we need long-term data on the functional outcome and the morphological evaluation in order to compare the results of the different surgeries and surgery versus substantial. So finally, we study the functional outcome. Most of our children do well, they have normal lives. But again, in metopic synostosis, there may be some delay. And in his series, Renier, who did a retrospective analysis, and he found that when children with all types of synostosis operated after 12 months, they had a poorer developmental outcome than when they were operated earlier. So there were certainly some biases. Maybe they were operated late because they were syndromic, or maybe the family was unmotivated by surgery, and all sorts of bias were possible. So other studies have shown that the delay was not correlated by the severity of phenotype, and even the reverse was found by Simogi. He found that there was more delay if the child was had a less severe trigonocephaly. So maybe there was a bias, and two subgroups in this study, and according whether they were referred for dysmorphism or for delay. So this has to be analyzed. And in the Lille series, we found that among 188 patients operated for metopic synostosis, the risk factors for delays were most of all syndromic, because obviously this syndrome can involve chromosomal disorders and severe problems. And we found no significant, no statistically significant correlation with birth dystocia, birth trauma, and age at surgery. However, there may be some confusion problem. If there was there a brain compression? So does the age at surgery has an impact? Is there a syndrome? If there is a fetal valproate or chromosomal disorder, we can expect there is some developmental delay. And was there dystocia? It can cause brain trauma or fetal anoxia, like in this child. And finally, was there some surgical complications and brain ischemia caused by low blood pressure during surgery? It has to be questioned. So we finish with the ethical and legal implications, because this is a largely aesthetic surgery with potentially little consequences. So we have to balance very carefully the benefit-risk ratio and take the decision, obviously, with the parents. The responsibility regarding the operative complications are shared with the anesthetist. That means we have to communicate before, during, and after surgery. Surprisingly, there are very few legal actions taken, and certainly the best protection against this legal action is good practice. We have to inform the parents, we have to be present whenever there is a problem, and we have to question whether safety is in number, and certainly we do well what we do often, and centralization is certainly an important way of reducing the complication rate. I thank you for your attention.